understand and hear about cannabis, which you all call marijuana, but we like to call it cannabis, and my story and why I feel compelled to go to senior retirement communities and centers to talk about the benefits of cannabis for sleep, pain, anxiety, and appetite issues. As David said, my name is Peggy Anderson, and I founded CannaHelpYou a year ago after I did a pilot presentation at the Mirabella, and we had 90 residents that came to the presentation, and we had the Knox doctors, Dr. David and Dr. Rachel, they're related, and David's wife, Dr. Janice Knox, who's a retired anesthesiologist. Dr. David is an emergency room doctor at Providence, Milwaukee, and his daughter, Dr. Rachel Knox, is with the American Cannabinoid Clinic, which is a clinic. As you can imagine, it's a medical clinic, but they also encourage maybe using cannabis as an alternative medicine to some of the prescription drugs you all are taking. So people say, well, why are you doing this? So my story is I broke my back when I was 17 with a water skiing accident. And the doctors were very generous in their opiate painkillers to get me through this time of my life. And move it fast forward, I was diagnosed with fibromyalgia in 1982 and found that the only thing to alleviate the pain was 16 Advil a day. I knew I had to walk every day to keep my body moving, good sleeping patterns, and food. My diet was very important at that time. As I found out that night vegetables were something that I shouldn't be eating, tomatoes are good for people with fibromyalgia. So I really took it upon myself to learn as much as I could about fibromyalgia. And then in 2014, I woke up and I couldn't move my legs. And by the end of the week, I couldn't move my hands to my mouth. Went to the doctors. They gave me prednisone, cortisone, Flexerol, amitriptyline, oxycodone. And they said, we don't know what you have, but this will make you feel better. Well, it dumbed me up. So I really took my health in my own hands, and I learned more about cannabis than I ever thought I would ever learn. And I knew cannabis has THC in it, which we'll be talking about today, and CBD. And CBD is an anti-inflammatory that comes in with cannabis. And so I used close to 100 milligrams of CBD during the day. And then to help me sleep at night, I would use CBD and THC and sleep probably almost 7-8 hours straight, which was important for me because if I moved when I was sleeping, I'd wake up from excruciating pain. After 7 months, my physical therapist said, you're 100% disabled, Peggy, and I don't know what to do for you. You've got to have a goal out there. You were very active a year ago, and so what's that going to look like? So I said I'll do a half marathon. I'll walk a half marathon in a year by the end of 2015. And she said, that's quite aggressive, but I'm here to help you. So for the next 8 months, we worked and worked and worked, and I came through. And I was never diagnosed. But I did that half marathon, and I was working at the Chamber of Commerce at the time, and recreational cannabis became legal on October 31st, 2015, and the owner of the dispensary asked a little bit about my background, and I told him what I had just been through, and he said, okay, you've got to become a cannabis medical advocate, and you need to get out and talk to seniors, because I'm 65 years old, and I want to live for the next 20 years feeling pretty good. And I don't want to be high, but I know how important CBD is to me and my body and how I go about my daily routines. So 2 years ago, I met the Knox doctors, and as I said, we did a pilot project at Mirabella last year, and they were with me, and I never looked back. We aren't here to sell products. We are here to inform you and educate you. The Knox doctors work with doctors all across the United States to help educate them as using cannabis as not the last alternative, but one of the first things to consider in improving your health. So with that, I'd like to introduce Dr. David Knox and his daughter, Rachel.
Okay, well, Dr. David Knox, and I've been doing emergency medicine for 40 years. Some of you may have had the misfortune of meeting me. Been there at Providence, Milwaukee for 38 years, and I'm going to be retiring in the next month, but you know, been a long gig. It was about 4.5 years ago that I kind of got introduced to cannabis medicine. You know, to that point, I was pretty much cannabis naive. You know, medical cannabis had been around since 1999, and you know, you hear about it. You see patients come in and say, "I'm on medical cannabis." I say, "Yeah, fine. You know, well, what are you here for?" But once we got into it and started seeing patients primarily for medical authorization, it was really eye-opening. And you know, my wife, Dr. Janice, could tell you the same story. It was just amazing. The patients that you expected to see were not the ones you were seeing. We were seeing, you know, all kinds of age groups, lots of older folks, just like you guys, history of medical problems. You know, I've seen complex medical histories I never saw in the emergency room. But they were finding good success with cannabis for treating their conditions. And as an emergency room physician, the biggest deal to me was the number of folks who kept telling me, you know, I was able to get off my opiates. I was, you know, able to cut down my opiates. I function a whole lot better. So that was the start of my learning experience about cannabis. Since then, we've all taken upon ourselves really to get educated about, you know, the science behind cannabis, you know, how it works, how it can be used efficaciously. So that kind of you know, led us down this line here. As my daughters went through medical school and residency, we were becoming educated, and we were able to, you know, help guide them a little bit on getting educated about cannabis medicine as well. So they, you know, decided to join us. So we formed the American Cannabinoid Clinics, and you know, we've you know, basically actively become students and educators about the endocannabinoid system. And that's why we call ourselves the Cannabinoid Clinics. We really are focused on your endocannabinoid system. The question is, how many of you are aware that you have an endocannabinoid system? Okay. That's a pretty good response, okay? And, you know, in comparison, Dr. Janice gave a talk to the residency program in pediatric oncology at OHSU, and we have more response to people knowing about endocannabinoid system here. It's still something that is not taught in medical school, barely touched on in residency, if at all, which Rachel can speak to. So, but you know, it's I feel it's a new science. I mean, it is so eye-opening what we're learning about it here.
Well, it's old science, new field of medicine.
Mm-hmm. Absolutely.
So for some context, I graduated from medical school in 2012, finished family medicine residency in 2015. The endocannabinoid system was discovered in its entirety in 1990. All the receptors, the ligands, and everything else that works in that system, 1993. So you can see there was a huge time period where they could have started integrating the information about the endocannabinoid system and all the things that it does into medical education, and they did not. So yes, my parents encouraged both my sister and I, my sister, Dr. Jessica, who lives in California, so she can't be here with us today, encouraged us to learn about the endocannabinoid system, and like my dad mentioned, we were fascinated by it. You know, I went into family medicine wanting to have a broad fund of knowledge so that I could help people heal. What I quickly learned in medical school, and then again, it was reinforced in residency, is that I was just being trained to prescribe drugs and to refer for procedures. I wasn't equipped with tools to uncover the root causes of disease to help people reverse diseases. Our leading causes of death in this country are number 1, heart disease, so heart attack and heart-related issues, cancer, and number 3, death by prescription drug. Okay? As a family medicine doctor, bread and butter was heart disease and diabetes, complications of which land you with a heart attack or a stroke. Diabetes is as closely related to Alzheimer's, is closely related to the development of cancers. And then what do? We prescribe prescription drugs. So right there, in the family medicine setting, where I'm treating people that are likely going to die from one of those top 3 causes of death that are preventable, really infuriated me. So when my sister and I left our respective residency programs in family medicine and preventive medicine, it made sense to us to do something that we felt could really help people reverse disease, improve their quality of life. And we don't like to say the C word. It's a nasty word in the world of pharmacology and pharmacy, and that's cure. Right? We've seen people reverse their diseases into remission, dare I say cure, their conditions with cannabis therapies. So together, yes, we founded the American Cannabinoid Clinics. We consider ourselves endocannabinologists, so kind of like endocrinology, cardiology. We are doctors and scientists, really, of the endocannabinoid system. We study the function and dysfunction of the endocannabinoid system and apply things like cannabis and other tools to that system to improve health and encourage healing.
Just to make it short, the endocannabinoid system is really the largest physiologic system in the body. You've heard about all the other neurotransmitters, serotonin, GABA, dopamine, norepinephrine. The endocannabinoid system really is a feedback mechanism for all of those. More than that, it's involved with your immune function, which is involved with so many disease processes. It has some effect virtually in every organ and tissue in the body. The complexity is really kind of fascinating. People wonder, well, how can it be so effective for so many different things? And it just comes down to because your endocannabinoid system is involved in virtually all of those symptoms.
Yeah, we'll get into that more. So to sort of get us into that direction, we are doctors of that system, right? We do specialize in cannabis, but we're not cannabis doctors. We're doctors of the endocannabinoid system because that's the system that we want to manipulate and modulate and supplement so that the conditions that most people have that are related to that system can improve. So we also like to talk about the history in as brief as we can because understanding the historical timeline of cannabis and prohibition and legalization really brings, I think, a lot of rich content and context to what we do and why what we do is so important. So I'll just read a few of these things in brief. So in the Chinese text, a very ancient Chinese text called the Qianan Ben Cao Qing, we found the first literary reference to cannabis as a medicine. That was in 2737 BC. From that point in time, all the way to the 1800s AD, we can trace cannabis, or the cultivation of cannabis and the use of cannabis for medical purposes throughout the world. Starting in the Himalayas, we came west through Europe, deeper Asia, so India, Africa, and then finally wound up in the United States Pharmacopoeia. Where's my date up here? 1854 to 1941. Cannabis made up 50% of the preparations American doctors, prescribed to their patients.
My summary on prohibition, it was a policy that was founded in racism, perpetrated by big money and politicians who saw hemp and cannabis as a competition. Were able to get it past the fools in Congress. And then subsequently, even Nixon disregards his own commission in order that he could continue to use it as a tool to suppress the hippies and minorities that he felt were political opponents.
I'll just jump in with the date. So in 1937, the Marijuana Tax Act was put into place. At the time, there was a doctor / lawyer / politician representative of the AMA, the American Medical Association, who did testify to Congress that cannabis, not marijuana, which is what the term that they were using, again, the Marijuana Tax Act, that doctors didn't agree with that. It was a very effective medicine and that it should be studied, not prohibited. And doctors were very angry because they were throwing around this word marijuana. They had no idea until this tax act went into place that marijuana was the same thing as cannabis. So there was a lot of treachery around that. And then 1970, with the Controlled Substances Act, Nixon signed into law basically final, nail in the coffin that cannabis is a Schedule I drug, has no accepted medical use, is highly addictive and dangerous, and easily abused. And obviously that's what we're fighting against to this day. What else do we have up here? Oh, very important to note, while all this was going on, so even before 1970 where cannabis found itself as a Schedule I drug, CBD and THC, which Peggy mentioned, were isolated. 1963 and 1964 to be exact. So the United States actually funded an Israeli biochemist, organic chemist by the name of Raphael Meshulam. And they funded, I think it was to the tune of $100,000 a year for him to study cannabis, the plant, and how it worked on people, very interestingly. Because they were able to isolate these molecules, they could synthesize them. So in 1985, Manor, if you guys are familiar with Manor, anybody in here familiar with Manor, the synthetic THC? In 1985 was when the FDA approved it. It was initially scheduled, I believe, 2, moved to Schedule 3, but basically doctors could prescribe it. And it was prescribed for anorexia, so poor appetite, and wasting conditions. And the 2 wasting conditions that were cited by the FDA was cancer, and chemotherapy-related nausea, vomiting, and poor appetite from cancer, as well as AIDS. So the wasting syndrome that we saw in AIDS. We allowed people to use Marinol.
What I find interesting about that is that, there's still a lot of criticism about cannabis, so, we don't know enough about it. On the other hand, the FDA approves Marinol before they even knew how it worked. And, the difference is, Big Pharma, was able to produce it,
Yep.
They were involved.
So 1985 was when Marinol was approved. We used synthetic THC, Marinol, radio-labeled to discover the endocannabinoid system. So in essence, THC molecule was tagged with a radioactive substance, let loose in the human body, and what scientists discovered was a system, a very intricate system throughout the brain, the rest of the nervous system, all of our end organs that THC sort of pinged. And that uncovered the endocannabinoid system. So between 1988 and 1995, finally all known components of the endocannabinoid system were described, and it became known as the system that controls every other physiologic system in our body. We like to describe this system as like the conductor or the maestro of an orchestra. And its principal function is to keep your body in balance, perfect health. Okay? So legalization, very interestingly, Oregon was the first state to decriminalize in 1973. In 1996, California legalized the medical use of cannabis. It's the first state to do so. In 1998, Alaska, Oregon, and Washington all legalized. Unfortunately, in 2016, the DEA maintained cannabis as a Schedule I substance, despite all the evidence to the contrary. However, in 2018, just a few months ago, the FDA did approve Epidiolex, the first whole plant-derived cannabis medicine, and they scheduled it, what was it? 5, right? So
That's right next to
the least abusive, right? Yes, darn near over the counter. But that does not mean that cannabis preparations of any other sort have been moved from Schedule I. They have not. And so, what's next? Well, we're what's next. So as I mentioned, the ECS, the endocannabinoid system, is a machine inside of your body. It's a network of receptors, ligands, the things that work on those receptors to create downstream effects, and enzymes that create those ligands, those molecules, and break them down.
Yeah, I think that, we kind of keep it simplistic, which we ought to have in physiology. You've got your receptors, you have the agents that work on those receptors, and then you have, the enzymes that break it down. What's interesting is that, the CB1 or the CB2, those were the cannabinoid receptors first discovered by that radio tagging and all. But then you start looking at the next line, the TRP receptors, PPAR, GPR55. There are so many membrane receptors throughout the body in all kinds of cells that the cannabinoids work on. And so we talk about CBD and THC as the major cannabinoids, but there's 120 minor cannabinoids, there's 420 terpenes, other molecules that affect all these receptors in the body. And so they can all have a physiologic effect. It's kind of like the more we learn, the more we know we don't know. The complexity is pretty amazing. But this is, as a starting point, kind of a simple explanation of major effects.
Okay, so the endocannabinoid system, like I mentioned, it keeps us in balance and in perfect health. When this machine breaks, what do we have? Dysfunction. So common diseases of ECS deficiency are migraines, fibromyalgia, IBS, obesity, and schizophrenia. Diseases of endocannabinoid system overactivity are inflammatory and autoimmune diseases, type 2 diabetes, rheumatic disease, which would go up in that first camp, cancer, and fibrosis. Okay, so if the machine breaks, what do? We fix it. So this endocannabinoid system is now a target for research. We want to know what is causing the dysfunction in the system, what's causing deficiencies, what's causing overactivity. And what we do, we focus on dysfunction reversal. And that's where we like to talk about precision medicine. Every single one of you and us has our own endocannabinoid system that is sort of tuned to a different frequency. We all have different states of endocannabinoid function at any given time during the day, right? You can talk about having different disease processes going on inside of us, but from minute to minute, that endocannabinoid system in your bodies is going like this, trying very hard to keep itself into balance, keep itself in balance and correct things that are going wrong. One of the principal therapeutic products to correct dysfunction is cannabis, so that's why we're here today to talk to you guys about cannabis.
And referring to the endocannabinoid system, all the things that affect it, it's still kind of comes down. The phytocannabinoids are still our kind of biggest tool in the box here, but and other things we focus on, everything from diet, nutrition, exercise, all these other things that affect your endocannabinoid system. You've been finding out some of the common therapeutics like Tylenol or acetaminophen essentially works on the endocannabinoid system for what it does. It took a long while to figure that one out. But acupuncture works on the endocannabinoid system. So massage can work on the endocannabinoid system. There's so many other things that affect it as well. So we try to incorporate all those tools into it. But of course, in this day and environment, the cannabinoids, the phytocannabinoids, that is plant-based, is probably the biggest tool in the box.
Right. So just very simply, if you have a deficiency in your endocannabinoid system, you might not be making enough of the cannabinoids that your body makes on its own. You might not have as rich of a receptor expression, or you might not have enough of the enzymes that create those molecules or break them down. And so why does cannabis work? So on the left are the endogenous cannabinoids that we call endocannabinoids.
That's the ones your body makes on its own. And,
yes.
They're kind of made locally, with synapses, and they're act locally, they break down locally.
You have anandamide here, 2-AG here, THC and CBD here. They look very different. There's some similarities. But essentially, this guy right here mimics the activity of these two here. CBD doesn't act the same way that THC does, sort of it acts synergistically with it. The endocannabinoids and phytocannabinoid mimicry, that's what I just mentioned. The molecules inside the cannabis plant mimic molecules that our bodies are supposed to make on their own. Okay, I think a great illustration of how THC might work to treat pain is when we have an overactive synapse that's shooting out glutamate, we'll say glutamate, that's a pain signal to a postsynaptic receptor. So he's the presynaptic, I'm the postsynaptic receptor. You know what I'm trying to say.
Yeah.
And he's shooting that glutamate toward me unchecked. So if any of you guys have neuropathic pain that doesn't get better day in and day out, It's this signal that's not dampening, that's not turning off, that keeps on throwing itself at me. What your body is supposed to do is form anandamide on its own from my side, travel backwards, we call retrograde, to the presynapse, and shut it off. So that signal goes away. When we have a deficiency and we don't make anandamide, it doesn't get shut off, and that pain signal keeps on going. So when we take a puff of, something with THC in it, that THC comes directly to that presynapse and shuts down that glutamate from shooting over to me.
And can we just mention you don't have to smoke it? There are other
We will. We'll get there.
Absolutely.
We'll get there. So we have mimicry. We call it mimicry. But then we also talk about full spectrum cannabis medicine. That's whole plant medicine. If you guys are familiar with, functional nutritionists, we like to talk a lot about full this, whole plant, whole everything, because the whole in nature is better than those isolates. And in cannabis, beyond the phytocannabinoids, the THC and the CBD and all the minor cannabinoids that we talk a lot about, there's other things like terpenes. Are you guys familiar with essential oils, like diffusing essential oils or using essential oils? Well, those essential oils are chock full of something called terpenes. Terpenes give all botanicals their flavor and their aroma. So when you smell a rose, you're inhaling little molecules called terpenes. They're very medicinal. That's why a lot of essential oils work medicinally. Lavender is a great example. If you take a whiff of lavender, some people don't like it, but if you do and it relaxes you, it's because a linalool, which is a terpene in lavender, calms you. Well, linalool is one of the dominant terpenes in cannabis. So when Peggy mentioned that she used some THC to get to sleep at night, there's some linalool in that formulation at all. It'll only help achieve relaxation and calm and help induce sleep. So there's other molecules in that plant outside of this whole THC thing that scares people that provide medical benefit. And so in our clinics, we are talking to people a lot about, yes, different methods of consumption. You do not have to inhale, but we're talking about full plant medicine because there's other things besides the CBD and THC in some cases that are more important in treating certain conditions. So this is a lot of stuff that we don't have to get into. We'd rather spend our time talking to you guys and fielding, questions. But something that we do have to deal with in, the landscape of legal cannabis in Oregon is the difference between strains, is what lay folks call cannabis plants, where we call them cultivars or chemovars. We didn't dive too deeply into chemical profiles, like how much THC or how much CBD or how many terpenes or all the other things that are in a particular strain or product, but all of that is super important. We call that the chemical profile. And when we're talking about strains, we can find strains with specific or predetermined chemical profiles, but we call those chemical varieties. We don't call them strains. We also deal a lot with the sativa indica. How many of you guys are familiar with sativas or indicas? That means nothing. It means nothing chemically, it means nothing scientifically or medically at all.
It might put you in the ballpark a little bit.
Maybe, and really only to describe how it's making you feel, right? This energizes me, it activates me, it alerts me, that's a sativa. This sedates me, it relaxes me, it puts me to sleep, that's an indica. But does that tell us anything about how much THC, how much CBD, how many terpenes are in that product? No, not a thing. So when patients come to us talking about sativas and indicas, we're just like, set that aside because that means nothing. We're trying to
make it a little more scientific, you really got to look at what we call the profile, and that is, your CBD content, your THC content, the ratio, plus, your minor cannabinoids, the decarboxylated versus carboxylated forms. And then you've got all your terpenes. You can have exactly the same CBD and THC. You put limonene or pinene in there, you're going to be stimulated. You put myrcene in there, you're going to be asleep on the couch. That's how they interact so much. So we really want to know the whole profile of what you're getting. And strains can be different from one grower to another. One side of the plant in the sun, the other in the shade. Your constituents can be different and all. So to make it scientific, we really like to have the testing, really kind of know what the profile is, and try to be a little more exacting about it.
Yeah. We actually just had a meeting with a really cool company that's developed this map of a lot of the chemical varieties available in the United States. And it was very interesting to see that, you know, like a blueberry muffin strain in Nevada is very different chemically than the blueberry muffin strain in Oregon. And that sort of illustrates what you were just describing, that different growing conditions, I mean, whether you play music over your plant, what type of music you play over plant, can impact the chemical profile of that given chemovar. The other thing that I want to just highlight is the difference between grade and strength. So all the products that are sold legally in medical or adult use shops have passed Oregon standards of testing. They're not medical grade though. And they're not medical grade because they have not been tested for heavy metals, they have not been tested for mycotoxins, which are actually very important when we have immunocompromised patients using those products. Mycotoxins can absolutely wreak havoc on an immune-compromised person, and heavy metals. A lot of people, unbeknownst to themselves, are already burdened by a heavy metal level. Part of functional medicine is getting in there and testing people for heavy metals, because those things actually do significantly set people up for autoimmune conditions, fibromyalgia as well. So if any of you guys have amalgam fillings, those things leach mercury, and mercury is heavily implicated in autoimmune disease. What else over here? And then strength, right? We talk about medical strength, and for purposes of cannabis, you can have a very potent product in THC that is the appropriate strength for you or your condition, or one that's high in CBD and almost no THC that is appropriate for you and your condition. So medical strength, that's actually highly variable. We care most about the grade because we'll get into potency and the chemical profile that's necessary for the individual based on lots of variables in conversation with that person. But grade matters, and I hope to see heavy metals and mycotoxin testing in the future in our state.
Yeah.
Oh wait, quickly. So it's important to us, and this was a presentation that we gave to industry people, so cultivators, dispensary owners, etc., because there's a huge disconnect between industry and medicine. A huge unfortunate disconnect, which we're trying to bring that gap closer and closer. What's very important to us is that products are of high quality, so of high grade. There are companies who do take it upon themselves to go above and beyond, and they do test for everything, which is really great. That's of consistent quality, right? If you're using a product that works well for your pain today, you want to make sure it works well for your pain tomorrow too. That's continuously available for the same reasons. That's consistently effective, and that's affordable. Because right now, insurance does not cover cannabis medicine. Okay, broad ranges of products are necessary. We encourage covering all routes of administration. And this is because everybody has different needs, right? So we have our pulmonary varieties, we call them pulmonaries. So these are smoking and vaping products, or inhalables. We have our ingestibles, capsules, what else? And tinctures. Capsules, tinctures, and oils can all be ingested. Edibles, if they're medical grade, do not contain refined grain, dairy, sugar, artificial sweeteners, industrial seed oils, preservatives, artificial dyes, or food colorings. Now this is important because we get diabetics in our clinic all the time that tell us their pain is really well controlled on a cannabis product in the form of a gummy or a lollipop or a cookie. That's full of all these things that actually make their diabetes worse, right? And so it's important not to compromise or compromise what your goal is, right? Your goal is to heal. Your goal is to feel better. But if you're doing something that's opposed to what you're doing, we don't get very far very fast. You'll chase your tail. Next, we have transmucosals. Transmucosals are things that get absorbed into your mucosal membranes. So the nasal septum, your buccal mucosa, so your cheeks, sublingually, under the tongue. And also vaginally and rectally, which will actually come down here, suppositories, but they are transmucosals. And then we have our transdermals, our topical lotions, creams, salves, and patches. So there's so many varieties to choose from. And there are a couple of factors that go into what we might recommend, because patient preferences matter. I mean, I've had patients who, they only get relief by smoking, and I don't deny them that. And then I have patients who only get relief by juicing, and that works for them. I'm not gonna dare say, actually, you should do something else when that's working well for you, right? Our job is to listen to our patients.
Yeah, there's so much variability. I'll see 2 patients in a row. One will say, you know, hey, I never do that. Well, they don't ever do anything for me. And another person says that's all they rely on.
Yeah.
And, you know, everybody's endocannabinoid system a little different, and you know, everybody's preference a little different. You know, so we often, you know, just use all the ways. You know, if you got bad joints, peripheral neuropathy, start with a topical. If the topical's not doing it, then go to a mucosal route, you know, under the tongue, tincture or oil.
And that's really an and/or statement?
Absolutely, you can you know, combine them. You can go to the oral route, you know. It's just physiologically we handle it a little differently. Suppositories in particular give you one of the highest bioavailabilities of the product, and probably, you know, across the nation, you know, 50% of medical users still prefer smoking. Big reason is it works very quickly. It's very titratable. You know where you are with the response very quickly, and you know, that's the easiest thing for a lot of folks. So.
Right. So what goes into all of that decision making are the following. So onset of action. People who want really quick relief, inhaling is the way to go. Duration of action. How long do you want your relief? Right. Inhaling also has a short duration of action, 2 hours, whereas, you know, a capsule or an edible or an ingestible can give you up to 8 hours of relief. Therapeutic blood levels that we want to see are very, very important when we're dealing with things like cancer, where we need a lot of cannabinoids in that body to help fight that cancer directly. THC tolerance. There are some people who need a lot of THC because of the condition that they have that don't tolerate the unwanted effects of THC at all, so we have to talk about how to increase that concentration slowly to, one, the minimum effective dose, and sometimes we have to go above and beyond that, and so we talk about bringing in other options like suppositories. So THC dominant suppositories, because there's a lot that has to do with that. The lower third of the rectum enters the systemic blood circulation, whereas the upper 2/3 enter the hepatic. And through the hepatic system, THC becomes way more potent.
Okay. So
we can sort of avoid that from happening by a rectal suppository. So we get creative depending on THC tolerance, and then lastly was the lifestyle needs.
You comment a little bit about the oral route. You know, like I say, being in the emergency room, that's still the patients that we do see occasionally when people have misused an oral preparation. Usually, you know, baked goods or that type of thing. They may or may not realize that it was magic. But the physiology is so
different. Laugh at that.
And, you know, when you eat it, you know, it takes several hours really for it to get absorbed. Bioavailability is so variable, and it depends on the permeability of the gut, what else you've eaten. The cannabinoids are fat soluble, so if you have a fatty meal along with it, you're going to get more absorption. But it takes a while. You know, onset can be anywhere from like 45 minutes out to 3 hours. And everything that's eaten in the intestinal tract goes to the liver first. And the liver is responsible for metabolizing all of the cannabinoids. Just if you inhale it, you know, it eventually goes to the liver. But if you eat it, everything goes to the liver first. The first metabolic byproduct of delta-9 THC is called 11-hydroxy-THC. It's a modification of a side chain. The 11-hydroxy, though, is about 5 times or more psychoactive. That is, it attaches to the brain receptors much more affinity. And when you eat it, everything goes to the liver first, so your serum levels end up about 5 times higher. So a lot of times, you know, with that delay, people say, oh, it's doing nothing, so they have some more, and then 3 or 4 hours, they are in big trouble, because now you get all those unwanted side effects that we can see with real high THC doses. Your heart's racing, you're anxious, you're paranoid, you're hallucinating. You know, people are going to have a very unfortunate time with it. So you do got to be really conscious of your THC doses. You got to be very patient when you're dealing with the oral route. But once you have experience, it'll last longer. It can last 8 hours, even more sometimes. So if you got chronic pain, you can titrate that dose so you get much more sustained relief, and it can be very, very useful. But that's part of what we do. We just help guide people how to use it, avoid those problems, and get to your optimal management of symptoms.
What about overdose? Overdose?
Overdose. Well, the definition of overdose, it's like not really important because it's 2 words. Overdosing, it's pretty simple. We understand what that means. You have an overage of your dose. So can you overdose on cannabis? Yes, you can. Has there ever been a documented death by overdose on cannabis? Nope, there has not. And the principal reason is because your brainstem that controls your heart and your lungs doesn't contain any cannabinoid receptors, right? It contains a lot of opiate receptors, and that's why when you overdose on opiates, your heart can stop, and your respiratory drive can stop, so you don't breathe anymore. Well, with cannabis, that can't happen. So that's why we've seen no deaths from cannabis overdose, and when we talk about overdose, we're really talking about the unwanted effects of THC, and some people don't mind those effects. Right, and so it's really unfortunate that we demonize THC and demonize cannabis for its euphorogenic and intoxicating properties, when we have tons of agents out there that are legal that do that and do it in a deadly fashion. Does that answer your question?